All right, so thyroid and parathyroid glands, blood supply, head and neck. Infected thyroglossal duct cyst. Okay, yeah, we're going to talk more about that and talk about the embryological origins of your thyroid gland and how when your fetus, like as your thyroid gland is developing, it actually travels down your thyroglossal duct, which is how you can end up with an infected thyroglossal duct cyst. Okay. Oh, well, she talks about it here. Perfect. So when you, let me actually look at pictures that she has here before I start talking. Nope. Okay. So I'm just going to talk about it first because she has words here, but I want to give you guys some explanation. I think that'll help. So your thyroid gland is this gland that's located in your neck. Is like below your thyroid cartilage. So here's your thyroid cartilage and like here's your thyroid gland. It looks like a butterfly shape. Here we go. It looks like a butterfly shaped gland. In most people, it's just this butterfly shape, but in a third of people, they have this accessory thyroid tissue. It's called the pyramidal lobe. You can see here. So that's about a third of people. So 2/3 of people just have this nice butterfly around the trachea, just below the thyroid cartilage. And then 1/3 of people are going to have this pyramidal lobe. Well, the reason why you can end up with this pyramidal lobe is that the thyroid gland doesn't actually originate like around the trachea. The thyroid gland originates at what's called the foramen cecum. And the foramen cecum is a spot at the back of the tongue. So the tissue originates there at the back of the tongue. And the foramen cecum, if you ever see the word foramen, a foramen is a hole. So the thyroid tissue originates at that posterior part of the tongue. It travels through the foramen cecum down what's called the thyroglossal duct. So there's actually a duct that goes from the foramen cecum at the back of the tongue down the midline of your neck so that the thyroid tissue can then be here around your trachea. And in normal situations, in most people, that thyroglossal duct, once the thyroid tissue is, around the trachea and the baby is born, that thyroglossal duct will go away. In some people, they have the remnant of this pyramidal lobe where the tissue, it was going down the duct. It didn't quite make it there, but it's fine. It's still in the midline. It's in the same area. Still gonna be able to do the same job. However, in some people, what ends up happening is that thyroglossal duct doesn't go away. And instead, because it didn't go away, you have this situation where it can get infected. And like I said, it's in the midline, like down the middle of your throat, anterior to your trachea. And so you can end up with a cyst, which is just like this fluid-filled sac that's there, and it can get infected. And the way that you can tell that it's a thyroglossal duct cyst, and they'll mention this like in questions when it comes to head and neck stuff, it's usually midline. And what you end up doing, like there'll be a bulge there, and you'll ask the patient to swallow, and you'll see the thyroglossal duct cyst elevate and then depress. So it'll move as the person swallows, and that tells you that it's a thyroglossal duct cyst because it's associated with that thyroid cartilage. And I mentioned this like in a previous session. When you swallow, your thyroid cartilage actually moves up and then moves down. So that's how you could tell. So she gets more specific with the location of it, how the majority of them are at the level of the thyrohyoid membrane under the deep cervical fascia. But that's that key point there, how it moves up and down when the patient swallows, and it's in the midline or just off the midline. So that's a thyroglossal duct cyst. Okay, so talking about the thyroid gland, so you can see here, this pink tissue here, that's your thyroid gland. Like I said, it's a butterfly shape. You have a left lobe and a right lobe that are connected by this middle part called the isthmus, which You can see better here. This is the isthmus. Here's your left lobe. Here's your right lobe. And you can see how it's surrounding your trachea just below the thyroid cartilage. And then there's your cricoid cartilage. And then you can see the tracheal rings. And this is a good cut so you can get three-dimensionally and understand like your thyroid gland is wrapping around your trachea and is on the sides of your esophagus. Okay, so she makes the point that is deep to your infrahyoid muscles. So your strap muscles here, remember they're attached to the hyoid bone up here and then various attachments below like your sternum or the thyroid cartilage. Let's see. Yes, and then she makes the point that it's anterior, and lateral to the larynx as well as the trachea. So the larynx, so making a distinction between the larynx and your trachea starts at this first tracheal ring. Your larynx is above it. So like where your thyroid cartilage is, and then your vocal cords are like down in here. This area is your larynx. So above the first above the vocal cords, think larynx. Below the vocal cords, think trachea. And so you can see how like your thyroid gland is surrounding all here. Let's see, fibrous capsule, loose sheath, pros versus cons. I don't know what she means by that note. It is highly vascularized. There are 2 to 3 arteries and 3 veins, and we're going to see them going forward. So again, left lobe, right lobe, isthmus, pyramidal lobe. So because, excuse me, because thyroid tissue moves down that thyroglossal duct and eventually settles here over the trachea, on occasion, the tissue might not end up where it's supposed to be. Most commonly, you have the pyramidal lobe, but you can have accessory thyroid tissue in other places, say muscles in the area. You can also have what's called a lingual thyroid. So because the thyroid tissue originates at that foramen cecum in the posterior aspect of the tongue, in some patients, like the thyroid tissue didn't travel down the thyroglossal duct. And so instead it's in the back of their tongue. And you find out about this during puberty because that's really when the thyroid gland starts ramping up production of thyroid hormone because it's important for like growth and metabolism. So puberty is when you find out about this. And you have to be careful because some people, like there have been instances where a lingual thyroid was mistaken for like some sort of mass and it was taken out and you basically took out all of the thyroid tissue that the patient had. Some people, like some of the tissue will go down to rest around the trachea and then some of it will be behind the tongue. So you have to test to see like, does this patient have any thyroid tissue around the trachea or is it just in the posterior aspect of the tongue? Let's see, what other important things? Oh, so before when we were talking about the fascia layers, just a reminder, your carotid sheath is getting contribution from the 3 different fascia layers. So you can see the contribution from the pretracheal fascia here, and it's also getting contribution from the prevertebral as well as the investing layer to create that carotid sheath. But you can see just how close the carotid sheath is to the thyroid in this picture. So here is our thyroid gland. Here's our trachea. There's that trachealis muscle I mentioned before. Here's your esophagus. This is recurrent laryngeal nerve. It's one of the branches of vagus nerve. There's a bunch. Don't worry about it too much. Just remember recurrent laryngeal nerve when it comes to problems with speaking, because that's another question that they love to ask about a person who has had some sort of neck surgery. And then when they come out of the surgery, they're now having difficulty speaking because the recurrent laryngeal nerve innervates most of the muscles that help with phonation, with talking, help you manipulate the vocal cords. So this recurrent laryngeal nerve, just have that in the back of your brain when it comes to like your vocal cords and the muscles that manipulate it, and questions about a person having difficulty speaking after surgery. Yeah, it's all that in that one picture. Okay, Some more about your thyroid gland. It is the largest endocrine gland. It produces thyroid hormone. Thyroid hormone helps you control metabolism, helps control the calcium balance. And so thyroid hormone is for metabolism. Calcitonin helps with calcium balance in your body. So when it comes to calcium balance in your body, that's regulated by calcitonin, which comes from the thyroid gland, as well as parathyroid hormone, which comes from the parathyroid glands. So let's talk about the parathyroid glands for a moment. You can see your thyroid gland, this beautiful butterfly around your trachea. On the back side of your thyroid gland, so this posterior aspect, you have normally your 4 parathyroid glands. Your parathyroid glands came from your brachial arches. Brachial pouches. That's a whole other thing with embryo. And when I talk to you guys on Tuesday, let me know if she brings up brachial pouches and arches and all that jazz, because I don't want to go too much into it because it can be confusing. What I will say is, like your thyroid gland, your parathyroid glands actually have to move into place. So they originate in these pouches and then they move down. So because they do that, even though we have pictured here our 4 parathyroid glands on the posterior aspect of the thyroid, that's not always the case. That's just like the most common places. Let me see if does she show the picture with the, okay, I'll show it to you. There's this wonderful picture and more that, and now I just gotta find it in my slides, that actually shows you the percentage-wise most likely places where, oh no, it's facing parotid, darn it, that's the wrong slide deck. The most likely places where your parathyroid glands will end up, and it's all over the place. But anywhere in that general area and vicinity, this would be, where did I put thyroid and parathyroid from me? Maybe face and parotid. I know I have a thing on parathyroid somewhere. All right, I can't find it. I'll find it later. I'll have it at the ready for Tuesday. But yeah, so your parathyroid glands, most of the time they end up here, like in most people, but they can end up on your tracheal cartilage. They can end up on your trachea. They can actually even go further down and end up on your heart. So the parathyroid glands can get a little wonky. But the main takeaway that you need from this is that the thyroid tissue moves, the parathyroid tissue moves into place. And because they move into place, that means that you can have like pieces of the tissue not be in the most common places. But it's calcitonin from the thyroid gland and parathyroid hormone from the parathyroid glands that keeps the calcium balance in your body. And then she just talks about how the thyroid gland is highly vascularized, and you want that since it's creating thyroid hormone and it's creating calcitonin, you need to get that into the blood. So yeah, it's going to be highly vascularized so you can get it into the blood and then out to the body. Okay, so arterial supply. So recall this is our subclavian artery. And she's highlighted here your thyrocervical trunk. This is part of what I was talking about, the vitamin C and D mnemonic of the branches of your subclavian artery, and how vitamin stands for vertebral, internal thoracic, and then your thyrocervical trunk. The C is for your costocervical trunk, and the D is for your dorsal scapular artery. So from your thyrocervical trunk, you can see here how it has a branch that is your inferior thyroid artery. So that's one of the arteries going to your thyroid. Here, this is your common carotid artery, and as your common carotid artery goes up, it splits into internal carotid and external carotid. There are 8 branches off of your external carotid artery. One of those branches is your superior thyroid artery. So you can see how you have the superior thyroid artery coming off of the external carotid, and you have the inferior thyroid artery coming off of the thyrocervical trunk. So two main blood supplies to your thyroid gland. And then, does she show picture? Yeah, it's okay. I'll show you guys a different picture on Tuesday. So looking down here, you can see here's the arch of your aorta. And then here's your brachiocephalic trunk splitting into subclavian and, hold on, this is backwards. That's brachiocephalic. Oh, because we're on the posterior aspect, okay. So here's your brachiocephalic trunk. Here's your right subclavian with the thyrocervical trunk and then inferior thyroid artery. And then here's your common carotid artery within the external carotid artery and then your superior thyroid artery. So this is the right side. And then on the left side, it's still your inferior thyroid coming off of your thyrocervical trunk and your superior thyroid coming off of your external carotid. It's just that you no longer have that brachiocephalic trunk there. So recall how I mentioned that recurrent laryngeal nerve becoming important when it comes to voice and phonation. Well, the pathway of recurrent laryngeal is really funky. So you can see here, the nerve comes down, scoops, and this is the left side. The nerve comes down, scoops under the arch of the aorta, and then comes back up on the left. On the right, the nerve comes down and then scoops under the brachiocephalic trunk and then goes back up. And then like the left vagus nerve and the right vagus nerve, like they come down, but this actual recurrent laryngeal nerve is like comes down and then branches off and then scoops back up. So yeah, it's nutty. The pathway of that particular nerve. Your right and left vagus nerve are going to continue going down into your abdomen because they help with the innervation of your gut organs. So yeah, vagus nerve does a lot. But going back to the anastomosis of blood supply for your thyroid. So Dr. Austin here talks about your arteries between the fibrous capsule and the loose fascial tissue. And just true and false here. I don't know what those are referring to. However, for superior thyroid artery, just talking about how it's the first branch of your external carotid artery. It descends down to your thyroid, which you can see here, descending down. It pierces the pretracheal layer of your fascia and divides into anterior and posterior. And it supplies the anterior and superior aspect of your thyroid. So your superior thyroid artery, which is a branch off of your external carotid artery, is then going to itself split into anterior and posterior, which you can actually see here. So the anterior part going to the front of the gland and then the posterior part going to the back. For your inferior thyroid artery, it is the largest branch of your thyrocervical trunk, which again is coming off of the first part of your subclavian artery. It's running superomedially, so up into the middle. It is posterior to the carotid sheath, and it supplies the posterior and inferior aspects of the gland. So superior thyroid is going to give blood supply to the anterior and superior parts of a gland. And then inferior thyroid is going to give blood supply to the posterior and inferior parts of the gland. Okay. So this is another little quirky thing that they love to throw into questions. So the thyroidema artery, it's only in 10% of people. It's small and unpaired. It's just a single solitary artery. So note how here we're now looking at the anterior aspect of the thyroid gland. Here's the arch of your aorta. Here's the brachiocephalic trunk. And then you can see this artery that branches off and then gives blood supply to the isthmus in the lower portion of the thyroid gland. Again, this is only in 10% of patients. And in this picture, it's showing it branching off of the brachiocephalic trunk. However, it can actually come directly off of the artery of the aorta. It can come off of the right common carotid. It can come off the subclavian artery. It can come off the internal thoracic artery. This is one of those times where we say vasculature is variable. Well, this is one of the the variables that we talk about. Only 10% of people have it, but it's important because when you think about this, what happens if you go to make an emergency airway and you mistakenly go too low and you cut this artery? Well, if you cut this artery, it's under high pressure because here's the arch of your aorta. Your heart is right down here. This is like the highest pressure your blood is in the body. So you run the risk of a person bleeding out pretty quickly if this artery gets nicked. I believe that there are questions that mention how a surgeon is doing a procedure on the neck. They mistakenly nick a vessel, like a tiny vessel, and then the patient starts profusely bleeding from the neck, like arterial bleeding from the neck. And the question asks, what was the source of that blood? And the answer is the thyroid artery. Again, this is only in 10% of patients, but still it's something important to remember and to note and to be aware of so that you can check to see if your patient has it before they go in for their neck surgery so that you won't accidentally nick it. Yeah, and we talked about how it supplies the isthmus of the thyroid gland. Okay, now we're going to talk about veins. The veins that have to do with blood supply for your thyroid gland. So you have a superior thyroid vein and an inferior thyroid vein, but you also have a middle thyroid vein. So the superior thyroid vein accompanies the superior thyroid artery. So again, two vessels, same area, so they get the same name. And your superior thyroid vein drains the superior poles, and it drains into your internal jugular vein. The inferior thyroid vein is independent, and it drains the inferior poles, and it drains into your brachiocephalic veins. So superior thyroid vein drains into the IJV. Inferior thyroid veins drain into the brachiocephalic vein. Your middle thyroid vein is parallel with your inferior thyroid artery. So this is where it can get confusing because this is not common. Usually the blood vessels that run together have the same name, but this is one of those instances where they don't. So your middle thyroid vein runs parallel with your inferior thyroid artery. Your middle thyroid vein also drains into your IJV. Okay, and then just showing the different relationships of the blood vessels to one another and along with the gland itself. So you can see here's your thyroid gland. And now let's look at our arterial supply. Here's our superior thyroid artery. Superior thyroid artery. And then here's our inferior thyroid artery. Inferior thyroid artery. And now looking at the veins, we see how we have our, oh, are they labeled? There we go. So here's our inferior thyroid veins here, draining into our brachiocephalic veins. Here's our middle and our superior thyroid veins draining into the IJV. So middle and superior thyroid vein draining into the IJV, inferior thyroid veins draining into the brachiocephalic veins. What's important about this picture? Okay, so making note again of that recurrent laryngeal nerves that came off of vagus. So the vagus nerve came down, and then hooked around either the brachiocephalic trunk on the right or the arch of the aorta on the left to come back up as the recurrent laryngeal nerve on each side. So this is vagus on the left, vagus on the right. And then you can see, like, it's trying to show you the innervation of the muscles there, but I'm going to wait until like there's talk more about the muscles of the larynx, because that can get a little complicated. Okay, I really wish you would highlight once you want y'all to know from this. Okay, here's your left recurrent laryngeal coming back up again. You can see your blood supply, your inferior thyroid artery, your superior thyroid artery, your superior thyroid vein, your middle thyroid vein should be here, and then here's your inferior thyroid vein. 35-year-old was diagnosed with adenoma of the thyroid gland. This required excision of the lower pole of the gland and ligation of the artery supplying that region, which the following nerves accompanying the artery is most likely to be damaged if the surgeon is not careful. So recurrent laryngeal, you can see, and so this is showing it in company with the lower pole of the thyroid gland. Okay, so here is your recurrent laryngeal nerve, and you can see it in relation to the lower pole of your thyroid gland. Okay. Parathyroids. So I talked a little bit about this already, but again, here's the 1, 2, 3, 4 parathyroids on the posterior aspect of your thyroid gland. So they're called parathyroids because para means like next to or by. So literally they're right by the thyroid gland. So it's the parathyroid glands. And they get named for their position. So you have 2 superior parathyroid glands and 2 inferior parathyroid glands. And again, these are just the most common locations of them, but their locations can be variable, even all the way down to the arch of the aorta. And then again, because we see it in this picture, I'm just going to point it out. You can see your recurrent laryngeal nerves. So this is vagus, and then recurrent laryngeal hooks around and comes back up. Vagus, recurrent laryngeal, coming around and hooking and going back up. So let's see, what did she talk about for the parathyroid glands? Lies at the middle of the posterior border of the lobe of the thyroid within the capsule of the thyroid gland. Variable in position, it may lie. So this is just talking about how your inferior parathyroid glands tend to be more variable in position than your superior. Let's see, shape and size, oval or lentiform. Okay. So yeah, and they just get blood supply, like they share their blood supply with that of the thyroid gland because they're literally right by the gland. Okay, and then they have them in purple here. Same again. So again, parathyroid glands produce parathyroid hormone for calcium regulation. And I guess this is just like another picture to try and get you to understand better the relationship between your parathyroid glands and your thyroid gland. Superior most constant, inferior very deep into the superior mediastinum, which is the area where the heart is, which is what I was talking about, how it can go down and on the arch of the aorta. And then vessels, how inferior thyroid artery is supplying your inferior parathyroid glands. And then parathyroid veins drain into the thyroid plexus. And then, oh yes, so if you remove all of your parathyroid glands, the person can die. This is because your body constantly needs calcium. Remember that when it comes to muscle contraction, you need calcium, and that's all kinds of muscle. That's both skeletal and smooth muscle. So because your parathyroids help to regulate blood calcium levels, if you remove all of them, that means that you can no longer regulate the amount of calcium in your blood And so you'll end up dying because you can't like contract your diaphragm to breathe, and you can't contract any of your muscles because your calcium levels will be wrong. Okay. Sites for ectopic parathyroid glands. Okay, so this is a different picture, but it's showing the point that I was trying to make before, how parathyroid glands, they don't always end up where you think they're going to be. So again, the most common sites is at superior and inferior poles of the posterior aspect of your thyroid. However, they can travel down and not make it far enough, so they end up in like the constrictor muscles. So you can see that on the side here. Constrictor muscle. This is actually your esophagus here. So parathyroid glands can end up being implanted on your esophagus. And they can also end up in your mediastinum. So this is your heart. And so here's your sternum. And then here's your heart behind it. And the thymus is a different gland. The thymus is the organ for T cell maturation. And they're actually called T cells because they mature in the thymus. But you can actually end up with parathyroid glands on your, like implanted on your thymus as well, because your thymus is yet another structure that moves into place. Like it moves down the midline, or excuse me, it moves on the sides because it's another one that originated from your pharyngeal pouches. And it moves like down and settles on top of the heart. So because it moves, your parathyroids, which once again, I'll get more into this later if she goes into the embryo of it, but your parathyroids actually hitch a ride with your thymus as it's traveling down, and then they're usually supposed to just plop off here on your thyroid gland. Well, sometimes they don't actually hop off of the thymus and just keep going with the thymus until it settles over top of the heart. So that's how you can end up with parathyroid glands like on top of your heart, because they just rode the entire ride with the thymus going down. Okay, exploration of the tracheoesophageal groove at the level of the thyroid gland would reveal what important structure bilaterally. Okay, so I don't know what the tracheoesophageal groove is. However, the recurrent laryngeal nerve, like we've been talking about that before, how it's on, so the vagus nerve comes down, and then as it comes down, it sets off the branch or gives off the branch that is the recurrent laryngeal nerve. And then that scoops back up and then goes up to the muscles for phonation. It helps to innervate those structures. Okay. Any manipulation of the superior thyroid artery must be undertaken with care not to damage its small companion nerve, the So external branch of superior laryngeal. Let's look at that because I didn't point that out before. Okay, so you can see, I'll go back. So here is the external branch of superior laryngeal. Now recall that these are your constrictor muscles. The constrictor muscles form your pharynx, they form your throat. And the external branch of superior laryngeal nerve, which is a branch off of cranial nerve 10, this is the branch that's innervating those muscles. Versus recurrent laryngeal, another branch off of cranial nerve 10 is coming up from below. Vagus nerve does a lot. So this is just another example of how vagus nerve just keeps popping up in different areas with its different branches. And you can see, excuse me, you can see your superior laryngeal nerve accompanying your superior thyroid artery here. So superior laryngeal, and then superior thyroid. Okay. Which of the following is true of the inferior thyroid artery? Okay, so the answer is they often supply all 4 parathyroid glands. So let's talk about why the rest of these are wrong. They arise from the external carotid arteries. So we know that's not true. It's the superior thyroid artery that arises from your external carotid arteries. Your inferior thyroid artery arises from that thyrocervical trunk that cross over the superior cervical sympathetic ganglion. No, that's in the posterior aspect. Oh, hold on. Superior cervical sympathetic ganglion. No, that's something you haven't learned yet. So we're just not going to talk about that. And they supply most of the anterior surface of the thyroid gland. No. So remember how the inferior thyroid arteries, they're on the lower side. So they're giving you the lower portion of your thyroid gland, like giving that blood supply, versus superior thyroid artery is doing like the upper part. And it seemed like it's split anterior for posterior when it comes to like blood supply on the front of the gland. If I can find a picture. Oh yeah, so yeah, that's mostly superior that's doing the anterior portion versus here's inferior doing the inferior portion, inferior and posterior portion. Okay. All right, well, she put in the picture, so now I feel like I have to talk to y'all about the branches of your external carotid artery. So you can see here's your external carotid artery, excuse me, here's your common carotid artery, and it splits into your internal and external carotid artery. The internal carotid artery is going up to help with the blood supply of the brain, versus your external carotid artery does a lot of the blood supply of the neck, like the head and neck. And yeah, there are 8 branches. She has starred these 2 branches specifically because they are the 2 terminal branches of your external carotid. So that is another fact that you're going to need to know. So superficial temporal artery and maxillary artery are the 2 terminal branches of your external carotid artery. However, the other 6 branches. So I know that there's a mnemonic for this, but I didn't memorize this as a mnemonic. I memorized this by tracing them on my face, which just sort of worked for my brain, and just imagining them branching off to go what they need to do. And a lot of these, again, their name tells you where they're going and what they're doing. So we've already mentioned superior thyroid artery. And then so superior thyroid artery going to give blood supply to the thyroid gland. It also makes a note here of this branch, the superior laryngeal branch coming off of superior thyroid artery. So superior thyroid artery is the first branch. And then you have ascending pharyngeal. It's literally going up to give blood supply to the pharynx. So ascending pharyngeal is your second branch. And then you have your lingual artery, lingual meaning tongue. Then you have your facial artery. Then you have your posterior auricular artery. So posterior auricular going to the backside of the ear. And then let's see, you have your maxillary artery, and then there's your superficial temporal artery. I feel like there's another one. There it is, occipital. I'm like, I thought there was an occipital artery. So you can see occipital artery here. And remember, occipital is that back portion of the skull. And then this picture is also showing you branches that go to the sternocleidomastoid muscle as well as a descending branch. But yeah, so occipital is another branch off of your external carotid. So I learned it as, and once again, I was like tracing my neck to sort of draw it out and remember the different branches and where they're going. So it was superior thyroid, ascending pharyngeal, lingual, facial, posterior auricular, occipital, and then maxillary and superficial temporal. And I guess it sort of helped me because I paired them. Because I remembered superior thyroid and ascending pharyngeal dealing with things that were mostly in the neck, lingual and facial dealing with like the mandibular area, posterior auricular and occipital dealing with like the ear and the back of the skull, and then maxillary and superficial temporal artery being the 2 terminal branches. But yeah, make sure you know those just in case. Okay. So your external jugular vein. So your external jugular vein versus your internal jugular vein. The difference between the two, your internal jugular vein is draining the blood coming from your brain versus the external jugular vein is all about like more superficially your head and neck, so your scalp and your face. So you can see it here. It begins just behind the angle of the mandible. So here's your angle of the mandible. By the union of the posterior auricular vein, which would be here. So posterior auricular behind the ear. With the posterior division of the retromandibular vein. So here's your retromandibular vein, and then here's the posterior division. So posterior auricular vein, and then posterior branch of the retromandibular vein come together to make your external jugular vein. I'm going to make a quick note here. Facial vein is going to become important when you talk about spread of infection on the face going back into the brain. So I'll just put that bug in your ear for later when she possibly mentions it. Right. And you can see this a little bit better on this picture. So here's your posterior auricular vein. Here's the posterior division of your retromandibular vein. And together they make your external jugular vein, your EJV, instead of the IJV. Okay. Is she talking about IJV now? Yes, I think this is talking about IJV now. Okay, so I'll make a mention. I'll talk about the internal jugular vein now. So the venous system that drains the venous blood in your brain is interesting because they're made up of sinuses. So they're not actual veins, they're empty spaces that are made by the meeting of meninges in your brain. And so they're sinuses. There's no valves. The vein just drains passively because of gravity. So you have all of these sinuses that you don't need to know their names yet until she shows them to you because there's a bunch. But what you do need to know is that your IJV starts as it's exiting from the skull. So like there's a sigmoid sinus here, which then drains into your IJV. Your IJV is very big because it's getting a lot of blood. So here's your IJV as it is exiting out of the skull and then coming down. Versus your EJV, you can see external jugular vein. You can see how it is not as big as your IJV because it's draining blood supply from like the scalp. So here's that posterior auricular vein. Here is the posterior part of the retromandibular vein. And then here is your EJV. So IJV, excuse me, versus your EJV. All right. What would be important in this picture? So let's talk again. Well, I like to make the point because I find it to be really interesting that your two brachiocephalic veins have different lengths. Your right brachiocephalic vein is super short versus your left brachiocephalic vein is long because it has to cross over to the right side of the body to meet the other brachiocephalic vein. When they come together, they form the superior vena cava, and the superior vena cava drains directly into the heart. So, excuse me, on both sides of your body, your IJV, your internal jugular vein, meets up with your subclavian vein to form your brachiocephalic vein. So this is your IJV, and then this is your subclavian vein. Other things that we can see in this picture that we've talked about. Okay, so here's your vagus nerve traveling down and then recurrent laryngeal branching off and scooping under on both sides. We can see blood supply to the thyroid, where you have your inferior thyroid artery coming off of your thyrocervical trunk, as well as your superior thyroid artery coming off of your external carotid artery. You can see the venous blood supply of the thyroid gland here, how you have your superior, your middle, and your inferior thyroid veins. And recall that superior and middle are draining into the IJV, but inferior is draining directly into your brachiocephalic veins. What else can we see in this picture? Yeah, I think that's enough. Okay. Identify the surface anatomy. Is this an animation? Nope. Okay. So just looking at the surface anatomy of this person, I don't know what she specifically could have wanted you to know, but the things I can point out, so here's your jugular notch, here is your sternocleidomastoid muscle. So this is the part that's on the sternum, this is the part that's on the clavicle, and then they come together. Here is Adam's apple, which is going to be your thyroid cartilage. What else could she possibly want you to identify from this? Maybe your external, I think this might be your external jugular vein, I think, because that's the angle of the mandible. But that's all I got because she didn't put anything else on this slide, so that's me guessing. Okay, so 3A and 7. So this looks like your common carotid branching into your internal and external carotids. I think that's what that is. Obviously, you guys will learn what that is if she didn't give you the answer here. Yep, you'll learn about that on Tuesday. Identify the structure being lifted by the probe. I think this is the ansa cervicalis. It looks like the ansa cervicalis to me. So you can see here the contribution from C1 and then C2 and C3. So I think this is the ansa cervicalis. And also because you can see it's resting on the IJV and the common carotid artery. So I'm going with this being the ansa cervicalis. You guys will find out if I'm right or if I'm wrong on Tuesday. And that is it, which is great timing because we're at 11:52. So I am going to stop sharing and stop the recording now.